pediatric ankle injuries, not only the fractures. I'm Waleed Kishta, I'm assistant professor, pediatric orthopedic at McMaster University here in Hamilton, Canada. I just finished my clinic. I know it's a Friday in Egypt, but it's working day here. So I know you enjoy Friday more than us. Actually, most of my practice is pediatric foot, which is very interesting, interesting practice. We see a lot of pediatric foot deformities. Now I see a lot of more sport injuries, maybe more in Canada. I know in Egypt, injuries around the ankle are very aggressive. Kids are more monkey, but I see a lot of interesting foot and ankle injuries right now. I'm going to start with this article that we published 4 years ago now, since I was in London at Western. So we made this article to come out with a classification for pediatric lower extremity or lower upper extremity injuries based on the secondary ossification centers. Try to make things easy. So we came out with this classification, classifying the injuries based on the ossification, because we found the ossification of the secondary ossification center is a good sign on the X-ray. So for example, pre-ossification is more common to have non-accidental trauma or child abuse, especially around the elbow. And the way to roll out that if you get the diagnosis with the X-ray, that's fine. If not, we'll get an arthrogram or an MRI, or some centers are good with ultrasound. When they get the ossification, it's easy to see the fracture, but sometimes you can miss it. The best example for this is an elbow dislocation, while you get the medial epicondyle avulsion fracture incarcerated in the elbow, and that's commonly missed even after reduction. And that's another entity. Then we classified the third group as a pre-fusion group, or some people like to call it the transitional fracture, which is the most common for the ankle injury, is the transitional ankle fracture. Also the apophyseal fractures, like Dr. Wael Nasser talked about the apophyseal injuries around the proximal tibia, also the avulsions, most commonly around the pelvis. These are common entities happen at the age of around the puberty. It's very interesting. We also published another paper about anterior superior iliac spine fracture and anterior inferior iliac spine. And we did a review article about the age and the mechanism of injury. It was very interesting. It's in GBGS case connector. And by the way, this study is open access, so feel free to read the study. We put an example of every entity based on the ossification center. So now moving to the ankle. The ankle joint, as you all know, is formed by tibia, fibula articulating with the talus. Talus is very special bone. I was hoping that I could have time have a talus case fracture in children. I know it's very rare. I know Dr. Lawindi did the talus fracture in adults last week. And I had in my practice only 3 patients in children with a talus fracture. But talus is very interesting, mostly articular, and has no muscle attachment, and very important bone. It's very sensitive, has mostly cartilage, weight-bearing area, mostly broad at the posterior, has the neck talus, famous with AVN, and the articulation with the tibia is a hinged joint. There are the rest of the anatomy. We all know the medial malleolus, lateral malleolus, and the ligaments around the anterior. This is from the posterior view. This is the posterior talofibular ligament, and the calcaneofibular ligament, that's from the back. Looking from the sides, also we know the deltoid ligament from the anterior ATFL, anterior talofibular ligament, and from the posterior we have the posterior talofibular ligament, and also the calcaneofibular ligament, and then the interosseous talocalcaneal ligament as well. Rest of the anatomy, as we all know, movements, principal muscle for dorsiflexion and the plantar flexion. So physical considerations, the distal tibial physis accounts for 35 to 40% of overall tibial growth, and about 15 to 20% of the lower extremity growth. The growth rate is about 3 to 4 millimeters per year, and it continues to age of 14 in female and 16 in boys or in male. Closure occurs during an 18-month at the transitional period. That's why we call it the transition fractures around the ankle. The distal fibular physis continue to grow 12 to 24 months after closure of the distal tibial physis. This is very important to understand the growth and also the direction of closure of the growth plate of the distal tibia. That also make us understanding how the fractures are specific to the distal tibia. The start of closure, starting from the medial side, going to the center. So the last part to fuse is this lateral part. And this will explain why we see the tail fracture commonly at this age group between 13 and 14. Sometimes I see it very rarely under the age of 12, but this is extremely rare. I know that Dr. Muhammad Hijazi talk about the Salter-Hurst classification.
Yeah, Professor Muhammad Osama Hijazi.
Dr. Osama Hijazi.
Yeah.
And you know, Salter-Hurst type 1, type 2, type 3, it's epiphyseal, type 4 including epiphyseal, metaphyseal, and type 5 is the crushing one through the epiphysis. That came by Dr. Salter in Toronto. He's just my neighbor here. Incidence, the distal tibial physeal injury is the second most common. It's 25 to 40%, and accounts for 5% of the pediatric fractures. It's more common in males, as usual, and typically happen between 8 to 15 years. Although I see, like recently, I've seen one 4 years old had distal epiphyseal fracture, but that's extremely rare. Risk factors: sports participation increase the BMI. Sorry, I missed the eye, but and the third one is the foot deformity. We see a lot of ankle injuries around cave-over foot or flat foot, or some people with coalitions, either with flat foot or not. This mechanism of injuries, that's a classification came by Tajian, supination inversion, supination external rotation, or pronation eversion with external rotation, or supination with plantar flexion. That's a Tajian classification with Dias. Usually you get the usual imaging, AP, mortis, lateral, 3 views for the ankle, and optional views, which I always prefer to get the full length of the tibia to roll out Maisonneuve's type of injury, or sometimes I've seen missed proximal tibia fracture in kids, which is very common, and we know it's common with the causing phenomena, and they come with pain, and the emergency doctor saying, I couldn't see any fracture on the distal tibia while they're taking only X-ray around the ankle. Then we do the full tibia, you see a proximal tibia fracture. I've seen this a couple of times. CT scan, it's an important tool to assess fracture displacement, and it's also good for the preoperative planning. There's the ankle series, AP, mortis, and lateral view. Let's talk about the tail fracture. We just mentioned that closure starts at the medial side and the lateral side still unfused, that make it in a weak situation, that with the injury can cause Salter-Hurst 3 fracture at this lateral aspect, especially anterior. And we know this is attached to the anterior inferior tibiofibular ligament, and that mostly can cause avulsion of this piece of bone. It happens in 3 to 5% pediatric ankle fractures, more common in girls, which is, it's actually, this is what I see, seen in children near skeletal maturity between 12 and 14, and typically occur within 1 year of complete distal tibial physial closure due to the pattern we talk about. And this age group is quite older than the triplane fracture age group that we're going to talk about now. Mechanism of injury usually is supination, external rotation injury, and causes avulsion. And associated fracture can be the distal fibular fracture, Salter-Hurst 1 or 2, and ipsilateral tibial shaft fracture can happen. That's why we need to get a full tibial X-ray. CT scan can show us the fracture pattern and also rule out any associated malleolar fracture. Treatment, so some do closed reduction pinning using a K-wire as a joystick, and then use a cannulated screws. And the common question, is it okay at this age group to cross the physis with a screw or not? I personally, if the patient is around 12 or 13, I don't cross the physis. If the patient comes at the age of 14, especially female, and have difficulty getting the screw and the physis, I can cross the physis. I don't have any issues with the growth remaining. Talking to the point of closed reduction versus open reduction, keep in mind this is an intra-articular fracture, and sometimes it gets as a periosteum entrapped, and most of the time you need to go inside, take the periosteum out, and to get a perfect reduction. This is my favorite way to do. The other way is I recently started to do more, is I do arthroscopic guided reduction. So I get the advantage of minimally invasive closed reduction plus arthroscopic guided, and they give me also better view for any associated intra-articular cartilaginous injury, and show me that the reduction is perfect as I need it, using the fluoro as well with the screw. For the open reduction, it's usually an anterolateral approach to visualize the joint line, remove any periosteum entrapped, can do arthroscopic assisted reduction as we mentioned, and we can do the indirect reduction with periarticular clamp. Screws are cannulated screws, usually use 4.0. If can take 4.5, that's fine. 4.2 usually is enough, and 1 screw is usually enough. Do your best to be epiphyseal, but if the patient is close to finish his growth, and it's difficult to get the shot for the epiphyseal screw, it's okay to cross the physis in older kids. Say in older is about 14 in female and in about 15 in boys. So we use the intra-articular, intra-epiphyseal cannulated screws 4.0, and we keep them. What I used to do right now is quite different, is I keep them in a slab for 2 weeks, and then I put them in an air boot after 2 weeks, non-weight bearing still, for a total of 6 weeks, but the advantage of air cast is it's removable, so they can get range of motion of their ankle to avoid the stiffness and also avoid significant calf atrophy. The triplane fracture, which is very specific as well, and is seen in children between the age of 10 to 17, and it's characterized by a complex Salter-Hurst 4 fracture. It's hard to understand this fracture, but we'll try to make it easy. So with a triplane, to diagnose, so the incidence 5 to 15%, and it's more common in male, that's compared to the TLO fracture we just talked about, and occur in children during their physial closure. So their average is younger than TLO, and as we know, is the juvenile ankle physis ossifies in a specific order that leads to transitional fracture. This is what we talk about. The start closure from medial to the center, leaving the lateral intact. That's why this is younger than the tilo fracture. Mechanism of injury. There are two types, lateral and medial triplane. The lateral triplane, usually supination, external rotation. Usually medial triplane, similar to adult, it's an adduction injury. Can be two, three, or four part fracture. Is the epiphysis is often fractured on the lateral aspect in the sagittal plane, and the physis is separated in the axial plane, and the metaphysis is fractured in the posterior aspect in the coronal plane and is seen in the lateral radiograph. It's very confusing. So let's make it easy for the juniors. You will see in the AP view, Salter has 3 fracture of the epiphysis. In the lateral view, you see Salter has 2 fracture of the metaphysis. That makes sense? So, and it's all 1 fracture. In total, it's Salter has 4, but because it's triplane and spiral and it's going through the physis, the way to diagnose it, you see 2 fractures, 1 vertical in the epiphysis, in the AP, and 1 sagittal metaphyseal on the lateral view. So here is an example for a fracture. It's more medial, so it's kind of oblique. So you see the vertical fracture in here, going through the physis. Is also fibula fracture. In the lateral view, there is a kind of small metaphyseal fracture there. So AP, vertical fracture in the epiphysis, lateral fracture, metaphyseal fracture. That's a triplane. They're all connected together through the physis. CT scan is helpful because sometimes it gives you more detail and it looks worse than what we think. And usually I like to do the CT scan after trial of reduction. We do the reduction opposite to the mechanism of injury. And as we said, if it's external rotation, lateral fracture, we do internal rotation for the reduction. So I start with pulling down, internal rotation, and some dorsiflexion. If you look at the axial CT, it looks like a Mercedes-Benz sign. Not sure if you like Mercedes or BMW, but Mercedes-Benz sign is very common around the ankle. Surgical treatment. So try closed reduction first. If the gap is less than 2 millimeters, especially for the intra-articular, you don't see any tilt. That means there is no periosteum entrapped inside, may be successful. It's better to follow the CT scan to assess your reduction. If not, go for surgical treatment. The best thing is open reduction, internal fixation. For me, there are some studies we'll just talk about now, talking about minimal invasive closed reduction, pinning or screws. But still the standard of care is open reduction. This is intra-articular fracture, plus it's physeal injury. Try to make it as perfect as you can to get the reduced articular surface and fix it. That fixation is easy with a cannulated screw, and you might add a metaphyseal fixation with the screws as well. For the lateral triplane, anterolateral approach, so can get you to approach the intra-articular fracture. This is the first step. Anteromedial approach for the medial triplane. For the lateral triplane, we mentioned that we reduce with internal rotation, we reduce with external rotation for the medial triplane. Recently, within the last couple of years, I like the arthroscopic assisted reduction, and I will show a case soon. Complications, commonly you see sometimes ankle pain. Most of the time I found it related to the hardware and screw, and sometimes because of malreduction. Extensor retinacular syndrome, typically with posterior displaced fractures. Malunion with rotation deformity is rarely seen Anterior angulation or plantar flexion deformity also, I see this rarely, and valgus deformity can also happen. Medial malleolus fracture, unfortunately, has the highest rate of gross disturbance. And I just seen one 2 days ago. Risk factors decrease, it depends on the degree of initial displacement, 15% increased risk of physeal injury for every 1 millimeter of displacement. Can represent periosteum entrapment in the fracture site, and this has been published by a study by Scott Mubarak, 2002 GBGS, talking about the periosteum, and especially if the residual physeal displacement is more than 3 millimeters. Talking about the growth arrest, it can be partial. Partial arrest can cause angular deformity. Distal fibular arrest can cause ankle valgus deformity. Medial distal can cause varus because the lateral side is growing, or complete arrest will result in leg length discrepancy. Physeal bar resection is indicated if there is less than 50% of physeal involvement, and there is more than 2 years of growth remaining, and if there is less than 20 degrees of angulation. If it's not, then osteotomy will be the treatment, and that has to include ipsilateral fibular epiphysiodesis, and that fibular epiphysiodesis is kind of guided growth from the lateral side to help prevent the varus deformity. To be said that when we have physeal bar at the periphery, medial or lateral, causes more deformities than the central one. The other thing is leg length discrepancy. If the physeal bar is less than 50% and there's more than 2 years of growth remaining, so resection can be reasonable. If not, contralateral epiphysiodesis as a timed growth or timed epiphysiodesis to get the growth matching will be the proper treatment, and it's a different topic. There is now the application that you can get the timing of epiphysiodesis done through the multiplier or Bailey app. There are some evidence based about using the CT treatment for TLO. Does it change your management plan? It shows that it only changes the management plan in 4% or 4.8%. How about the arthroscopic assisted percutaneous fixation of triplane? It's just few patients, small power study. I might have way more than this number, but not published. It shows that you go through the normal follow-up, 2 weeks assessment, shows that screws are good. To be honest, from my practice, it shows me the major advantage of using the scoop and the ankle is it shows me other injuries in the cartilage, which is very surprising to see different other injuries other than the fracture itself. And that can make me comfortable saying to the family that the prognosis might not be good in your case. Percutaneous versus open. With this study, it shows that the open has more higher rate of postoperative pain, and that the need for hardware removal. That's probably when we open, we make scarring, and that can cause pain. Honestly, I don't see this high number. And from the study itself is not significant. There is a case, I don't want to keep you up late, but this is a 13-year-old young athlete who had injury of her left ankle while doing gymnastics, complained from pain and swelling. Here's a fracture. I'm not sure if you can see in the AP a vertical fracture or in the lateral, but here's the CT. She had the typical, that's the typical, you see the AP in the coronal, you see the vertical fracture on the sagittal, you can see the metaphyseal fracture. Here you can see it connected. It's a Salter-Harris 4 on the sagittal view because it's a CT scan, and you see the Mercedes-Benz sign on the axial. It's actually very, very good example that it's hard to see. This case can be missed easily. So what we did the arthroscopic assisted. You see the amount of cartilage damage inside? That's huge. And then we're able to do a percutaneous screw fixation with a fluoro. If you look here, there is another talus injury. And these cases usually come to me later with a chronic ankle pain. And this is one of the things don't want to miss. Another 10-year-old young, previously healthy, who had an injury of the left ankle while playing hockey. And they're very aggressive with the hockey here in Canada. And as they get a lot of crush injury, had this bad injury, and it's a peripheral, high risk of physial bar. We mentioned this from the first moment. That is where we have elected between surgical and non-surgical, tried the cast. We had some voting. We said, yeah, less than 2 millimeters, let's continue, and ended in this. I've seen him 2 days ago. It's like preparing for this lecture, and definitely has a bar medially, and I sent him for an MRI to get assessment for the amount of the bar. Is it less than 50%? Then we prepare him for physial bar resection and guided growth on the lateral side of the tibia and the fibula. And a treatment of post-traumatic pediatric ankle varus deformity with physial bar, bar resection and hemiphysiodesis is working quite good. So just resection of the bar and guided growth lateral. As you see, there's an 8 plate on the lateral distal tibia and also at the fibula as well, correcting the varus. If it's more than 50%, the osteotomy would be the answer, and maybe we'll complete the physiodesis. Another study talking about that's another thing. So go back to the studies. It's like comparing using the fluoro versus using the navigation system. There's no significant difference, but now we have a navigator and we have an O-arm in our hospital, so why not to use it as detecting the bar, as it's tricky to get the bar resection. So we're very close to the end. Just to mention some updates about the ankle fracture or ankle injuries in kids. There is an old statement saying kids don't sprain. So you get a child, have an ankle sprain, do X-ray, there is no fracture. We say this is Salter-Harris 1 of the distal fibula or the lateral malleolus, because kids don't sprain, their ligaments are stronger than the physis. That's why they get Salter-Harris 1, even if you don't see it. Bodis and Oni Narayan in sick kids did the study, and he said, I don't believe this, and let's do an MRI of these ankles. And then he found that 90% of the kids get sprain and not physical injury. So it's opposite to our old statement that we believed on. They tried to follow with another study, not to do a follow-up at the clinic with these kids. So an ER, they put them in a splint, and the patient takes the splint off once he feels better. I don't like this way, to be honest, because of my practice as a foot and ankle, pediatric foot and ankle, I see a lot of chronic ankle instability in children, more evolving than before. So I follow so you use the immobilization with the splinting for a couple of weeks, followed by intensive physiotherapy. Is there any value for the MRI in diagnosing injury after ankle sprains? I get a lot of calls from my friends in Egypt. They're worried about their kids. They get MRI same day, and actually the study shows that there is no difference. And I would say there is no need to do this to diagnose early ankle sprain. I had a patient last week. Mom was like bugging me to get an MRI for an ankle sprain. Finally, this is the last slide, I promise. I see a lot of recurrent ankle instability in children. I treat them, and what's my finding? I haven't published on this, but finding is I usually see this non-union of Salter-Harris 3 of the distal fibula or avulsion fracture, which is actually connected to the ligaments, and that causes instability. And most of the time, I know that the old fashion is people remove this and reconstruct the ligament, but most of the time what I do is I refresh it, fix it, sometimes with suture anchors, sometimes with the screws, and I do more of kind of reconstruction of the ligament on top of this with more plication. Also, for all of these kids, I always start with ankle arthroscopy and to assess the cartilage, and I see a lot of surprises. The last one of them had chondromalacia, was a very bad cartilage on the lateral aspect of the talus, and articulation was the distal tibia. Thank you very much. Sorry to keep you up, and I'm ready for your questions.
Thank you so much, Professor Waleed. We are not so late, Professor Waleed. You know, in Egypt, we sleep after 2 a.m.
That's good.
Yeah, we are not so late. In Canada, I think you sleep by 8 or 9.
No, we're still keeping the Egyptian habits.
Yeah.
So we're the only family in our street that stays up.
انا حضرتك اول مره نزلت المانيا يا دكتور وليد كان الساعه 9 بالليل، فانا فوجئت، انا اول مره اروح المانيا فوجئت ان مفيش بني ادم في الشارع. هو في ايه يعني؟ احنا طبعا عندنا بنبدا نشتغل بعد الساعه 12 بالليل، مفيش مشكله.
واحنا still the same.
Thank you so much. يعني محاضره اكتر من رائعه دكتور وليد بي. Thank you so much, sir.
Thank you.
We can take some questions, please. The first question.
ليه بس سؤال الاول على السوفت وير.
اتفضل دكتور قلبي.
السوفت وير او البروجرام اللي بيعمل ترانسليشن على طول ده.
انا لسه بسال عليه احمد علاء، لسه بسال عليه.
What's the question again؟
البروجرام اللي بيعمل سعادتك الترانسليشن بتاع الفويس لكلام. كنت لسه بسال الدكتور احمد علام عليه.
Yeah, is it yeah, you can see it.
ايوه فاهم.
اوكي. اصل دايما يطلع معايا مع الزوم، بس انا فاكره من الزوم نفسه.
لا مش بالزوم، احنا عايزين سر بقى.
بالظبط. انا كنت لسه حضرتك يا دكتور وائل بسال الدكتور احمد علام عليه، بقول له انا عاجبني قوي البروجرام ده.
يمكن انا عامل السيتنج، لان عندي ماك كمبيوتر. maybe the setting is from my side. But yeah, it's interesting.
We have a question, Professor Waleed. A 12-year-old patient with delayed diagnosis TLO fracture, about 3 weeks post-trauma. What's the best treatment for this case, in your opinion?
So again, if it is displaced more than 3 millimeters, I still go ahead and do open reduction within 3 weeks. After 3 weeks, it's very hard to be like healed and we'll see what luck we will get. But 3 weeks still, I can go inside and we be able to do a reduction again.
We have no other questions, Professor Waleed. بس احنا مش هنسيب حضرتك الا لما ناخد وعد بان حضرتك معانا في الكيس بيس ديسكشن بروجرام ان شاء الله اللي هنبداه. ده وعد من حضرتك ان حضرتك هتكون معانا يا فندم.
يس طبعا.
ان شاء الله يا دكتور وليد بيه.